osteoarthritis is a whole joint disease. Previously, we thought it was only a cartilage disease. Professor Ajah explained in his introduction that it could be a whole joint disease. And initially, we thought it's due to cartilage matrix breakdown. But we know now synovitis, subchondral sclerosis, and osteophyte formation and pigmented capsular contracture, everything contribute to the pathogenesis. You can see the normal cartilage on the left side, and the right side there is cartilage degeneration, there is synovitis, neoangiogenesis, subchondral sclerosis, and all these factors contribute to the pathology. So this is an osteoarthritic knee pathology. It's a sorry, so we think osteoarthritis is breakdown of the cartilage. That's not the only thing that's happening. You can see the subchondral bone provides hydration and oxygen to the cartilage. And there is a lot of inflammatory changes happening. There are cytokines released from the macrophages. Synovial fluid is decreased. Destructive proteins are released, and there is degradation of the cartilage and subchondral sclerosis. Osteophytes forms. So if you look at the etiology, there are various phenotypes which cause the osteoarthritis, not just the cartilage breakdown. So there is a different phenotype. It's a heterogeneous etiology. There is the age-driven phenotype, cartilage-driven phenotype, metabolic phenotype. It's called inflammation. Synovitis-driven phenotype, subchondral bone phenotype, and trauma-driven phenotype. Most orthopedic surgeons are familiar with the mechanical phenotype. So if there is a malalignment or loss of meniscal tissue, or there is a cartilage lesion more than 10 millimeters, or instability or trauma to the joint, it predisposes to osteoarthritis. So now we can address this malalignment or meniscal damage with the corrective surgery. We do high tibial osteotomy, meniscal repair. Now we have gone to artificial meniscus and meniscus allograft. Cartilage can be grown in the lab, and cartilage can be implanted. But the basic pathology we need to address, as we know, when the cartilage is broken down, it releases a lot of metabolic enzymes which stimulate the macrophages and the fibroblasts, that in turn causes a lot of inflammatory reaction. There is hardening of the cartilage matrix. There is subchondral bone sclerosis. There is synovitis. This again brings in a lot of inflammatory changes. And the release of cytokines accelerates the changes in the joint. So basically, it starts from because of the enzyme-mediated and cytokine release. The metabolic phenotype, where there is obesity or lifestyle-related problems, there is metabolic reprogramming. It's called inflammation. And there is cellular senescence. It's called SASP, cellular senescence-associated secretory proteins. These enzymes are released, which causes again inflammation and osteoarthritis. If you look at the mitochondrial level, the cellular level, the normal metabolism happens with glucose utilization via glycolysis and oxidative phosphorylation. But in aging and other reasons, the metabolism switch over from oxidative phosphorylation to glycolysis as the main source. So the mitochondrial metabolism is impaired. This leads to release of reactive oxygen species, which again starts inflammation. So now we move away from the traditional treatment consideration, just giving analgesics, physiotherapy, intra-articular injection, which are symptomatic relief, or finally arthroplasty. We are looking at prevention of disease progression. We're trying to attack the arthritis early and prevent progression. We're trying to have cartilage regeneration and reversal of cartilage damage. So the newer developments are targeted specifically to the particular phenotype. So, for example, we target the subchondral bone of the joint. We give biphosphonates and vitamin D so that the subchondral bone is stronger, there is no collapse. Then we target the cartilage metabolism. We give matrix metalloproteinase inhibitors, growth factors like spilfermin, cathepsin K inhibitors, which specifically address the cartilage strength and promote regeneration. We also address inflammatory mechanisms like IL-1 inhibitors, TNF alpha inhibitors, curcuma longa extracts. These all address the inflammatory mediators like IL-6, transforming growth factor beta, all these cytokines. We also address pain pathway. We directly address the pain relief by giving specific drugs which address the pain pathway, or sometimes we use intra-articular steroids as well. So it's very important to know what phenotype the particular patient belongs to. It can be a genetic or metabolic or injury related, so that we can give personalized care for this patient. We give particular targeted therapy. So for example, if cartilage is a patient is cartilage type phenotype, we can give sperformin, which improves the total joint cartilage thickness. The subchondral bone is weak, we give zoledronic acid to increase the bone strength. Cathepsin K inhibitor has been shown to reduce bone and cartilage degeneration. We target pain pathway by intra-articular transcapsaicin molecules. So similarly, the metabolic syndrome can be targeted by giving FOX2 inhibitors and metformin. So based on these phenotypes, we can address our disease pathology. So we focus on disease progression and cartilage regeneration. Personalized therapy is important. Phenotyping of OA is very important, and there's an active research happening so that we can individually address the particular phenotype and prevent cartilage degeneration and promote regeneration. Thank you for the opportunity.